Good afternoon, everyone. Today, I'm Dr. Srujana. I'll be discussing regarding neonatal thrombosis in the neonates. The subtopics which we'll be discussing today are mechanism of hemostasis, the risk factors for the thrombophilia, types of thrombophilia, the diagnosis and the management. Coming to hemostasis, it usually occurs in two steps. The first step, it is the primary hemostasis, which is the platelet plaque formation. And the secondary hemostasis, it is also known as the coagulation cascade. It is responsible for the formation of stabilization of the clot. Now, coming to primary hemostasis, it usually occurs in 5 steps. The first step is the endothelial injury. When there is an injury, then the exposed endothelial cells, the nerve that are connecting these endothelial cells and the smooth muscle cells, they detect this injury and triggers the reflexive contraction of the smooth muscle cells, leading to vascular spasm and resulting in the decreased blood flow and blood loss. Normally, the undamaged endothelial cells, they secrete nitric oxide and the prostaglandins, which into the blood. This causes the relaxation of the smooth muscle cells. But when there is an injury to the endothelium, it usually secretes endothelin that causes the vasospasm of the vessels. The second step, it is the exposure. That is the exposed damaged endothelial cells, they usually expose the collagen that is present underneath these cells. And these damaged endothelial cells, they releases the von Willebrand factor. These von Willebrand factor, they come and binds to the exposed collagen. Then the next step, it is the adhesion. Usually, normally the platelets, these are circulated in the blood as the megakaryocytes. And these platelets, they come in contact with the von Willebrand factor that is bound to the collagen with the help of glycoprotein 1b pro that is present on the surface of the platelets. And this forms the adhesion. Now, coming to the activation, the platelets which come in contact with the von Willebrand factor that is bind to the collagen with the help of glycoprotein 1b, these platelets, they become activated. Now, these activated platelets, they have released, they undergo various conformational changes with its in shape and releases the von Willebrand factor into the blood, also serotonin, calcium, adenosine diphosphate, thromboxane A2. These serotonin levels, it helps in attracting more and more platelets, whereas the calcium, it is used in the secondary hemostasis, and the ADP thromboxane, which is released into the blood, they activate the other platelets that are not bound to the von Willebrand factor and form a positive feedback loop. And this positive feedback loop, it is usually limited to the injury site. There are war between the platelet inhibitors, continuous war between the platelet inhibitors and the platelet activators. Normally, the undamaged endothelial cells, they secrete nitric oxide and the prostaglandins, and these prevent the activation of the platelets. And these are called as platelet inhibitors. Whereas the thromboxane A2 and adenosine diphosphate that are released from the activated platelets, they bind to the platelets with the help of glycoprotein 2b3a. And now these platelets become activated. And these are the platelet activators. Now, these adenosine diphosphate and thromboxane A2, they causes the platelets to bind to the collagen and also causes the floating platelets to express the glycoprotein 2b3a gene that binds to the fibrinogen. And this fibrinogen with the platelets, this help in binding the other platelets in the blood to the platelets that are bound to the collagen and increases more rapid aggregation of the platelets, finally leading to the platelet plaque formation. Now coming to the secondary hemostasis, this is also known as the coagulation cascade. This is nothing but these are the various steps that occurs in response to the bleeding that is caused by the tissue injury. So in this coagulation cascade, each step they usually activates the other steps and finally produces the blood clot. The extrinsic pathway, usually it begins with the damage to the endothelial cells by exposing the tissue factor to the blood. And these activated tissue factor combining with the calcium and activator factor 7, they activate the factor 10A. Whereas intrinsic pathway, begins with when the Hagman factor exposed to the collagen calcrenin, high molecular weight calcrenin, it activates the 12th factor. Becomes activated. This activated 12th factor, it further activates other factors like 9, 11, and 8 factor. And finally, this activated 9th factor and the 8th factor, they activate in combination with the calcium, they activate the 10th factor. Whereas the common pathway, they begin with the activation of the 10th factor with the help of intrinsic and extrinsic pathway, both independently. Now, these activated 10th factor in the common pathway, they combine with the factor 5 and calcium and further form a prothrombinase complex. These prothrombinase complex, they activate prothrombin to thrombin, and this thrombin further cleaves the fibrinogen to the fibrin. And the fibrin, with the help of binding to the calcium and 13th factor, activated 13th factor, they form the stable fibrin clot. There are various, thrombin has various actions. This thrombin, it may activate the factor 8, and it also activate the factor 5, and it also activate the prothrombin to it also activate the fibrinogen to fibrin and also the factor 13, that is the stabilizing factor. So the factors which are involving in the coagulation cascade, they are all known as the procoagulants, and they are anti-thrombotic factors which helps in the fibrinolysis. These are the tissue factor, plasminogen inhibitor, protein C or S deficiency, protein C or S, antithrombin 3, and antithrombin 3. Now, coming to the physiology of the hemostasis, it usually varies when compared to that in the adults, a little bit change in the neonates. Normally, these proteins which are involved in the coagulation cascade, they are produced by the fetus as early as 10 weeks of the gestation, but they do not process the placenta. Whereas the platelet count and the lifespan of in the neonates, they are similar to that of the adults. But the bleeding time and the overall assessment of the platelet function with interaction with the vascular endothelium, they are shorter in the neonates, leading to rapid platelet adhesion and aggregation, finally causing increased primary hemostasis. These are the protein levels in the neonates when compared to adults. The procoagulant factors which are elevated in the neonates when compared to adult values are fibrinogen, factor 5, factor 8, and von Willebrand factor. And the procoagulant factors that are decreased in the neonates are factor 2, 7, 9, 10, 11, 12, and 13. Pre-kallikrein high molecular weight kininogen. Whereas the anticoagulant factors that are increased are alpha-2 macroglobulin, whereas the anticoagulant factors that are reduced are antithrombin 3, heparin factor 2, protein C, and protein S. The fibrinolytic factors which are elevated in the neonates are tissue plasminogen activator inhibitor, and the fibrinolytic factors that are decreased in the neonates, they are plasminogen and alpha-2 antiplasmin levels. Now, coming to the factors which contribute to the thrombosis, this forms the Virchow triad. The factors, mainly they involve three factors. Initially, there will be a stasis of the blood or reduced blood flow or the stagnant of the blood flow. This causes increase in the clot formation. The second one is any damage to the endothelium, that is the lining of the blood vessels. It also further triggers the clot formation. And the hypercoagulability, it also increases the clot, leading to the thrombosis. Now, coming to the risk factors, the perinatal risk factors, they involve both maternal and the neonatal factors. Among the maternal or the placental factors, the risk factors are maternal fever, chorioamnitis, inherited thrombophilia, antiphospholipid antibody syndrome, prolonged premature rupture of the membranes, shoulder dysplasias, emergency LS cesarean section, preeclampsia or hypertension in the mother, diabetes mellitus or dyslipidemia in the mother, infertility, and the placenta causes like placental thrombosis and abruptio placenta. Whereas the neonatal causes, they involve low birth weight, prematurity, severe fetal growth restriction, perinatal asphyxia, thick meconium or meconium aspiration syndrome, male sex, infection, and thrombophilias. Now, coming to the postnatal risk factors, these seen in the neonatal causes. This involves central venous or the arterial catheters, which are most common cause for the thrombosis, septicemia, meningitis, birth asphyxia, thrombophilia, mechanical ventilation, congenital heart disease, congenital nephrotic or the nephritic syndrome, polycythemia in the neonates, respiratory distress syndrome, or surgeries, use of steroids in the premature babies, and total parental nutrition. Among these risk factors, these indwelling catheter, they are the most common cause and they're responsible for 80% of the venous and the artery and 90% of the arterial thrombotic complications. Asymptomatic thrombi, usually they are present in 30% of the newborns who are having UVC. Whereas the thrombosis due to the UVC, they causes a severe symptomatic vessel obstruction requiring intervention in approximately 1% of the patients. Coming to types of thrombophilia, there are two types. This involves inherited and the acquired thrombophilias. Among the inherited thrombophilia, this inherited thrombophilium, it is usually characterized by there is a positive family history, and they usually present at very early age, and these thrombophilias, they are very, very recurrent, and they are unusual of multiple locations on thrombophilic events. Genetic risk factors for this inherited thrombophilia is usually seen in 10 to 50% of the children with thrombosis. And the incidence in the neonates who are heterozygous for inherited thrombophilias are very small. But those who are homozygous for a single defect or the double heterozygous with the different defects, they usually present with significant thrombosis in the neonatal period. Among these homozygous prothrombotic disorders in the neonates, the most common is neonatal purpura fulminans. It is usually associated with homozygous protein C or S deficiency, and they are present within the first few hours or days of birth, and there is an evidence of atrial cerebral hemorrhage. This is the slide which is showing the prothrombotic disorders, which are the causes for the neonatal thrombosis. Among these causes, the factor V leading mutation, it is the most common cause. The other factors they are involved are factor 2, G20, 210A gene mutation, increased apolipoprotein levels, methylene tetrahydrofolate reductase gene mutation, hyperhomocystinemia, protein C or S deficiency, antithrombin 3 deficiency, heparin cofactor 2 deficiency, dysfibrogenemia, plasminogen activator inhibitor 1, 4G or 5G gene mutation, increased levels of factors 8C, 9, 11 of fibrinogen levels, antiphospholipid antibody syndrome, chromosome 2q or chromosome 2q13 deletion syndrome. Coming to acquired thrombophilia, usually this is caused by placental transfer of maternal antiphospholipid antibodies along with anticoagulant or anticardiolipin antibodies. There are other causes of catheter-related arterial or the venous thrombosis and the non-catheter-related renal vein or the neonatal stroke. Coming to venous thrombosis, this venous thrombosis most commonly it is due to central venous lines. And non-catheter-related, that is the spontaneous thrombus, usually occurs in the blood vessels like renal vein thrombosis, portal vein thrombosis, right atrial thrombosis, and the cerebral sinovenous thrombosis. Whereas the venous thrombosis due to idiopathic, it is usually seen in less than 1% of the cases. Now coming to the catheter-associated venous thrombosis, the umbilical vein catheter, it is the one of the most common cause for this type of thrombosis in the preterm neonates. The incidence usually varies from 21 to 71%, whereas the intracardiac thrombus that is due to the UVC placement, it ranges from 1.8 to 5.3%. The veins that are involved are portal vein, renal vein, and inferior vena cava. The clinical features who are present with catheter-related thrombosis, they involve difficulty in infusing through or withdrawing from the line, and the other signs, they include swelling of the extremities, head and neck, or distended vessels or the veins. Here, the diagnosis is usually confirmed by ultrasound with Doppler, and the other studies, they include radiography, line study, or venography through peripheral vessels. And there is also thrombocytopenia, it usually present with neonates with the central venous lines. This catheter-related venous thrombosis, it can be prevented by adding unfractionized heparin 0.5 units per ml to all the infusion lines at the rate of 0.5 to 1 ml per hour. UVCs and the peripherally inserted catheters, they should be intermittently flushed or infused with low-dose heparin to maintain the patency. And these UVCs, they have to be removed as soon as clinically feasible, and they should not remain in place for more than 5 to 7 days. The PICC line, it has to be placed if anticipated need for clean central access is more than 7 days. Coming to the management, if there is any non-functioning central venous line, we have to remove the catheter until that central venous line is absolutely necessary. If there is any local obstruction, then a low-dose infusion of thrombolytic agents through the catheter has to be done. If infusion through the catheter is not possible, then this central venous line, it has to be removed and heparin therapy has to be considered. If there is any extensive venous thrombosis, then anticoagulation therapy has to be initiated, that is followed by catheter removal after 3 to 5 days of anticoagulation. And these anticoagulation, it has to be continued until there is resolution of the thrombus. And this may take time for 2 weeks to 2 months. Now coming to the renal vein thrombosis, these are usually present in the first week of the life, and the incidence is 0.5 per 1,000 neonatal admissions. Usually they are seen in the term neonates and for the large for gestational age. These renal vein thrombosis, there are 70% of them are unilateral and 64% of them, they are involving the left side of the kidney. Males are more affected than the females. Whereas the incidence, it is most commonly seen in the infants of diabetic mothers. The other risk factors, they include perinatal asphyxia, polycythemia, hypotension, cyanotic congenital heart disease. Coming to the signs and symptoms of renal vein thrombosis, they usually present with a triad of there is a palpable flank mass and microscopic hematuria along with the thrombocytopenia. The other features include proteinuria and renal dysfunction. The diagnosis is confirmed with ultrasound with the Doppler. Whereas the complications, they include hypertension, renal failure, adrenal hemorrhage, extension of the thrombus into the inferior vena cava, and death. This renal vein thrombosis, it is managed based on the involvement of the renal vein. And if there is unilateral renal vein thrombosis without any significant renal dysfunction or without any IVC extension, then only supportive care has to be given. And the catheter, it has to be, or the UVC which is in place, they should be preferably removed. And we had to monitor for the extension into the inferior vena cava. Suppose if there is any extension into the inferior vena cava, anticoagulation therapy has to be started. In case of unilateral renal vein thrombosis with renal dysfunction or extension into the inferior vena cava and bilateral renal vein thrombosis, anticoagulation therapy with unfractionated heparin or the low molecular weight heparin, it has to be initiated and it has to be given for a duration of 6 weeks to 3 months based upon the resolution of the thrombin. And the patients with the renal insufficiency, if you are using the low molecular weight heparin, the dose has to be reduced. If there is bilateral renal vein thrombosis with renal failure, then thrombolysis, thrombolytic agents has to be started along thrombolytic agents like tissue plasminogen activator, it has to be started, and this has to be followed by the anticoagulation with unfractionated heparin or the low molecular weight heparin. Now coming to the portal vein thrombosis, it usually the incidence varies from 1 to 43%, and the risk factors involved are sepsis or omphalitis, umbilical venous catheters, etc. The diagnosis is confirmed by the USG with Doppler, and this showed cavernous transformation of the portal vein with splenomegaly. If there is any sign of reversal of portal flow, this indicates there is severity in the renal portal vein thrombosis. Now management, coming to the management, if there is no extension, then the patient is neonate is clinically stable, then we have to observe, and the ultrasound, it has to be done, repeat ultrasound has to be done at 7 to 10 days of life. Then suppose if there is extension into the inferior vena cava, right atrium or the right ventricle, but there is no end organ compromise, anticoagulation therapy has to be started. And repeat ultrasound has to be done after 10 days. If the thrombus is resolved, then we can stop this anticoagulation therapy. But if it is still present, then we have to continue it for 6 weeks to 3 months with the ultrasound follow-up. If there is an end organ compromise with the extension of the thrombus into the inferior vena cava, right atrium or the right ventricle, then thrombolysis has to be done and the ultrasound has to be done daily. And this thrombolysis can be stopped when the symptoms improve, but we have to transition into the anticoagulant agents. Coming to right atrial thrombus, the risk factors are central venous lines, and the complication, they include pulmonary embolism, cardiac failure. This can be treated by removing the catheter and anticoagulation therapy with the low molecular weight heparin. Suppose if there is any cardiac function is compromised, then thrombolytic therapy has to be started. Coming to cerebral sinus venous thrombosis, which is the most common cause of neonatal cerebral infarction, they are associated with epilepsy, cerebral palsy, and cognitive impairment in 10 to 80% of the cases. Here, the mortality rate, they usually ranges from 2 to 24%. And the most commonly, it is affecting the superior sagittal sinus, transverse sinus, and the right sinus. The risk factors they involve are infection, perinatal complications, and post-traumatic traits. The neonates who are having this cerebral sinus venous thrombosis, they present within first day to first weeks of life. The clinical features, they include are seizures, lethargy, irritability, and poor feeding. And the complications are hemorrhagic infection. It is one of the most common complication, and it is noted in 50 to 60% of the cases. Any term or the late preterm neonates who are having intraventricular hemorrhage or the thalamic hemorrhage, then we have to evaluate for the cerebral sinus venous thrombosis. This cerebral sinus venous thrombosis, the diagnosis, it is confirmed by MRI or MR venography. On MRI or MR venography, if there is no hemorrhage, then we can start unfractionated heparin or the low molecular weight heparin. Suppose if the hemorrhage is present, then we have to just observe and we have to repeat the MR venography in 5 to 7 days. And if the thrombus is propagating, then we have to start unfractionated heparin or low molecular weight heparin. There is no hemorrhage, and after starting unfractionated or low molecular weight heparin, we have to repeat MRI and MR venography in 6 weeks for vessel recanalization. If there is the vessel recanalization is complete, then we can stop the therapy. If not, we can consider six more weeks of the treatment. Now, coming to the complications of the venous thrombosis, there are short-term as well as the long-term complications. Under short-term complications, they involve loss of access to the vein, pulmonary embolism, superior vena cava syndrome, specific organ impairment. Coming to long-term complications, there is the edema of the leg, a pain abdomen, lower extremity, thrombophlebitis, varicose veins, leg ulcers, chylothorax, portal hypertension, and embolism. Now, coming to the arterial thrombosis, usually most of the causes for these arterial thrombosis are iatrogenic, and they are linked to the catheterization of umbilical, femoral, and the peripheral arteries. And these thrombi, they develop several days after the catheter removal. Spontaneous arterial thrombi in the aorta, they're very rarely seen in the neonates. The complications of arterial thrombus, they are also acute and as well as long-term complications. Under the acute complications, the causes are renal failure, hypertension, mesenteric ischemia, peripheral gangrene, and other organ failure and death. In the long-term complications, they include increased risk for atherosclerosis and the chronic renal hypertension. Coming to perinatal arterial stroke, here this perinatal arterial stroke, it usually in ischemia of the hemorrhage, it usually occurs at 20 weeks of the gestation up to or 28 days postnatally. The thrombi typically affects the left hemisphere within the distribution of the middle cerebral artery. This perinatal arterial ischemic stroke, due to the protraumatic disorders, they are associated with poor neurological outcome. In the guidelines, they recommend that perinatal arterial ischemic stroke, if it is associated with the proven in cardioembolic or the recurrent, then only it has to be treated with the anticoagulation therapy. The pathophysiology for this perinatal arterial ischemic stroke are the thrombus, which is formed in the placental vessels due to the placental pathology. They due to reduced reserve and a thrombo-inflammatory process, this enter into the fetal circulation through a patent foramen ovale, often blocking the left middle cerebral artery and causing the perinatal arterial ischemic stroke. These are the subcategories of perinatal stroke. The first one is neonatal arterial ischemic stroke. They usually occurs after birth, but before 29th day of life. In perinatal arterial ischemic stroke, it is very difficult to establish whether the stroke has occurred before, during, or after childbirth, but usually occurs from 20 weeks gestational age until birth. Presumed perinatal ischemia, they usually present with subtle symptoms, and later they are present with sequelae. The clinical features that are they usually presented are focal seizures, apnea, chewing movements, bicycling movements, persistent feeding difficulties, etc. And the other subtype is neonatal cerebral sinus venous thrombosis. Coming to iatrogenic or the spontaneous arterial thrombosis, the main risk factors involved are UAC and peripheral arterial lines. It also involves femoral arterial lines, especially in the neonates with congenital heart disease or those who require extensive surgery. The clinical signs of peripheral arterial line related thrombosis are limb ischemia, quale or cold extremities distal to the cannulation site. There are weak or absent pulses, decreased or non-recordable BP. This is the picture which is showing the distal ischemia and the limb ischemia of the upper limb. Coming to management of the peripheral vasospasm, if there are any symptoms of peripheral vasospasm, then the opposite limb, it has to be warmed for at least 15 minutes and look for the resolution of the symptoms. If there are resolution of symptoms, then just they observe them and look for the reappearance of the symptoms. If the symptoms reappear, then we have to remove the catheter. Suppose there are no resolution of the symptoms, then also we have to remove the catheter and remove the catheter and look for the symptoms. If the symptoms still persist, then we have to use 2% nitroglycerin ointment at 4 millimeters per kg and monitor for the BP levels of the neonate. Femoral artery thrombosis, this is managed based on its severity. There is acute femoral artery thrombosis with non-limb threatening. Start with the IV unfractionated hemorrhage. heparin. Then treatment has to be continued until the clot resolution, but it should not be more than 5 to 7 days. This may also be converted into low molecular weight heparin after 48 to 72 hours of treatment and continue until the resolution of the clot. If there is any limb threatening or organ threatening femoral artery thrombosis, we have to start with IV unfractionated heparin that is followed by the recombinant tissue plasminogen activator if the clot doesn't resolve or symptoms worsen. But if the symptoms do not improve in 24 to 48 hours, we may begin with recombinant tissue plasminogen activator with IV unfractionated heparin. If recombinant tissue plasminogen activator is complicated, then they need surgery for the femoral artery thrombosis. This arterial thrombosis, iatrogenic arterial thrombosis can be prevented by using high UVC positioning, which are fewer complications, by adding continuous heparin infusion at 1 unit per ml to prolong the catheter patency. The longer the UVC in place, the greater the likelihood of thrombus formation, with 80% incidence after 21 days. Usually UVCs, it should be removed. It should not be kept in place for more than 5 to 7 days. Coming to management of aortic thrombus, if there is a minor aortic thrombi with milder symptoms, then we have to remove the catheter. If there is large but non-occlusive thrombi, the catheter has to be removed along with an anticoagulation therapy has to be started. If there is large occlusive thrombi and it is accompanied by the significant organ compromise, then the catheter, it has to be kept in place and we have to see whether the catheter is patent or not. If the catheter is patent, then we have to use local thrombolytic therapy. If the catheter is removed or it is obstructed, then systemic thrombolytic therapy has to be used. Usually, there is no role for surgical thrombectomy in the neonates unless if there is any life-threatening or the limb-threatening thrombosis. Coming to the diagnosis for the thrombosis and the evaluation for the thrombophilia, initially we have to do complete blood count, which is showing thrombocytopenia, disseminated intravascular coagulation screening involving PT, APTT, INR, fibrinogen, D-dimer levels, the protein-based assays like protein C and S activity levels, antithrombin 3 activity assay levels, plasminogen levels, and DNA-based assays like factor V lead-in levels, and prothrombin G20-210A gene mutations. For protein-based assays, if the patient is having acute thrombosis, they have to be repeated at 3 to 6 months of age. Usually, these protein-based assays, they are affected by this acute thrombosis. If the neonate, if they are on the anticoagulation therapy, then also that protein-based assays, they have to be repeated 14 to 13 days after stopping the anticoagulation therapy. Whereas the DNA-based levels, this can be done at any time. In thrombosis, this is the slide which is showing that in the factors which are increased, hematocrit, MCV levels will be increased, von Willebrand factor levels will be increased. There is decrease in the antithrombin, proteinase, protein C, heparin cofactor 2. It's the slide which is showing prothrombotic disorders and the test that has to be done and the levels when it will get normalized. If there is antithrombin 3 deficiency, antithrombin 3 level has to be checked at 6 months of age and the patient neonate should be off heparin. And the sample collected is plasma. Protein C deficiency, protein C activity has to be checked at 6 months of age and it also checked with the plasma. Protein S deficiency, protein S activity has to be checked. It can be checked. This activity, it is normal at birth. But if you are checking the antigen levels, they're usually checked at 6 months of life because they are low. And the sample collected is plasma. Factor V leading gene mutation, the test to be done is G169-1A gene. It has to be done at birth and the sample collected is CDTA. For methylene tetrahydrofolate reductase, C677T gene and increase homocysteine levels which are done at the birth. For prothrombin gene mutation, G2020-10A gene testing has to be done at the birth. And lipoprotein A levels, it has to be done at 8 to 12 months of life. For antiphospholipid antibody syndrome, we have to check these antiphospholipid antibody, anticardiolipin antibody levels, lupus anticoagulate in the mother serum. Based on the vessels that are involved, the imaging modalities are if the arterial perinatal arterial ischemic stroke, it can be diagnosed by the diffusion weighted MRI or MR angiography. If there is iatrogenic or spontaneous arterial thrombosis, the diagnosis is confirmed by the Doppler ultrasonography. Venous thrombosis involving inferior vena cava, abdominal veins, lower extremities, renal vein or portal vein. The diagnosis is confirmed by Doppler ultrasonography. If there is cerebral sinus venous thrombosis, then the diagnosis is confirmed by diffusion weighted MRI or venography. If there is a thrombosis in the right atrium or the superior vena cava syndrome, then the diagnosis is confirmed by echocardiography. Now, coming to the management, this involves supportive care, anticoagulation therapy, thrombolysis, surgery, and then counseling. Coming to supportive care, the catheter, it has to be removed as early as possible, and local care has to be provided, food has to be elevated, and we have to treat the underlying signs like volume depletion or the shock, electrolytic imbalance, sepsis, anemia, and thrombocytopenia. Coming to anticoagulation therapy, usually it is indicated for larger occlusive arterial venous thrombus. The anticoagulants that are used are unfractionated heparin, low molecular weight heparin. Coming to unfractionated heparin, usually here the mechanism is heparin, they go and bind to the antithrombin 3 and it causes conformational changes that inactivate the thrombin and other proteases, particularly the factor 10A. And this unfractionated heparin, it has to be given for a duration of 10 to 14 days and it can also be used for up to 3 months max. Oral anticoagulants, usually these are not recommended in the neonates, but if the long-term anticoagulation is required, then we can consider low molecular weight heparin. The treatment, the dosage guideline for this unfractionated heparin are, if there is symptomatic thrombus but non-limb or the life-threatening and the gestational age is less than 28 weeks, first give the bolus of 25 units per kg IV over 10 minutes, followed by 15 units per kg per hour of maintenance dose. If the gestational age is 28 to 37 weeks, 50 units per kg IV over 10 minutes bolus, followed by 15 units per kg per hour of maintenance dose. If the gestational age is more than 37 weeks, 100 units per kg IV over 10 minutes, followed by 28 units per kg per hour of maintenance dose. Before starting unfractionated heparin, we have to see for the basic tests like CBP, platelet count, coagulation profile like PT, APTT, fibrinogen, D-dimer levels. And the platelet counts, it has to be repeated daily for 2 to 3 days. And once the therapeutic levels of this unfractionated heparin has been reached, then twice weekly. The effect of heparin, it is monitored by the heparin activity level, which is the most reliable test. And this heparin activity, it is considered therapeutic when antifactor 10A is maintained between 0.35 to 0.7 units per ml or protamine titration of 0.2 to 0.4 unit per ml. These antifactor 10A levels, it has to be checked 6 hours after initiating the therapy and then 6 hours after changing the dose. Anticoagulation due to unfractionated heparin, it can be reversed either by stopping the heparin, or if we want the rapid reversal, then we can give protamine sulfate at a dose of IV at a dose of 5 milligram per minute. Complications, they include bleeding, heparin-induced thrombocytopenia, and osteoporosis. Now coming to low molecular weight heparin, that is the enoxaparin, it has less effect on the thrombin when compared to that of the unfractionated heparin, but the same effect on factor 10A. And this is given for a duration of 5 days to 6 months. The advantages of low molecular weight heparin are decrease in need for laboratory monitoring. There is also decrease in need for dedicated venous access. It can be given subcutaneously twice daily. It also reduces the risk of heparin-induced thrombocytopenia, reduces the risk of bleeding at recommended doses. These are the dosage guidelines for the low molecular weight heparin. For symptomatic thrombus but non-life-threatening, the additional dosing for any gestational age is 1.5 mg per kg subcutaneously given every 12th hour. If the gestational age is less than, based on the gestational age, if the gestational age is less than 28 weeks, the dose required is 1.25 mg per kg subcutaneously every 12th hour. For 28 to 37 weeks, it is 1.5 mg per kg. For gestational age more than 37 weeks, it is 1.625 mg per kg subcutaneously every 12th hour. And the prophylactic dose that is used is 0.75 to 1 milligram per kg subcutaneously every 12th hour. Here the goal, it is antifactor 10A levels, it has to be maintained between 0.5 to 1 unit per ml. And the levels has to be checked 4 hours after second dose and then every few days of weekly. If the infant with high hemorrhagic profile, then the dosing regimen to be used is 1 milligram per kg subcutaneously every 12th hour. This is the slide which is showing the monitoring and the dose adjustment of enoxaparin and the monitoring of antifactor 10A levels. Suppose if the antifactor 10A level is less than 0.35, the dose it has to be adjusted is it has to be increased by 25%, and antifactor levels, it has to be checked 4 hours after the next dose. It is 0.35 to 0.49, then the dose increased by 10%, and levels has to be checked 4 hours and after the next dose. It is 0.5 to 1, then the dose, it has to be remain the same, and the levels has to be checked at 24 hours after changing the dose. If the antifactor level is 1.1 to 1.5, then the enoxaparin dose, it has to be reduced by 20%, and factor 10A levels has to be checked before the next dose. If the factor 10A levels is 1.6 to 2, then the dose, it has to be, enoxaparin has to be held for 3 hours, and the dose has to be reduced by 30%, and the 10A factor levels has to be checked before next dose and then 4 hours after the next dose. If it is more than 2, then enoxaparin has to be held until the level is 0.5 unit per ml, and the dose has to be reduced by 40%, and the levels, they are checked before the next dose. If the level is not less than 0.5 units per ml, then it has to be repeated every 12th hour. The anticoagulation due to low motor weight heparin, it can be reversed either by discontinuing the injections. If the rapid reversal is required within 3 to 4 hours of last injection, then protamine sulfate has to be given 1 mg in the last injection of 1 milligram low motor weight. Tissue plasminogen activator, they convert the plasminogen to plasmin levels, which this plasmin, they cleave the fibrinogen and the fibrin, leading to the formation of fibrin degraded products. For thrombolytic therapy, usually these are because of lower plasminogen levels at the birth, it has reduced effectiveness for thrombolytic agents in neonates. So the very less the need for thrombolytic agents in the neonates is less. If the plasminogen, if it is required and its activity to improve this activity, fresh frozen plasma at the rate of 10 ml per kg, it has to be given instead of increasing the thrombolytic doses. The preferred agent is tissue plasminogen activator, but due to its better fibrin specificity and more effective clot lysis. The indication for thrombolysis is usually it is not recommended unless there is major vessel occlusion causing the critical organ of the limb compromise. Before starting the thrombolytic agents, we have to check for the CBP, PT, APTT, fibrinogen levels along with the baseline cranial ultrasound. The dosage for streptokinase, usually streptokinase and the urokinase less likely used in the neonates. For streptokinase, the dose is 2000 units per kg over 10 minutes, then 1000 to 2000 units per kg per hour. Only one course has to be given for 6 hours. These are the dosing guidelines for the recombinant tissue plasminogen activator. If there is limb or life-threatening thrombus and the gestational age is less than 28 weeks, the dose recommended is 0.03 to 0.06 milligram per kg per hour. Along with this, unfractionated heparin has to be infused at a rate of 10 units per kg per hour. For more than 28 weeks, the same dose of less than 28 weeks can be used, or 0.1 to 0.5 milligram per kg per hour for 6 to 12 hours with repeat daily dosing for up to 3 days. Along with that, infuse unfractionated heparin at 10 units per kg per hour. The under monitoring, the dose escalation up to 0.24 mg per kg per hour, it can be considered, but they should be done very slowly with continuous monitoring. To increase the plasminogen supplementation activity, that is the thrombolytic activity, infusion of fresh frozen plasma at 10 ml per kg before the therapy is recommended. This is the monitoring recommendation for the thrombolytic therapy. Before initiation of any treatment, imaging thrombosis, it has to be done every 12 to 24 hours. For fibrinogen, it has to be done, fibrinogen level has to be done before initiating the therapy, 4 to 6 hours after starting the treatment, and every 12 to 24 hours. And the level, it has to be maintained minimum 100 milligrams per deciliter. Platelet counts, it has to be done before the initiating the treatment, then 4 to 6 hours after starting the treatment, then every 12 to 24 hours. And the minimum platelet count should be maintained is 50,000 to 1 lakh. Cranial ultrasound, it has to be done before starting the treatment and then daily during the treatment. Coagulation test, it has to be done before starting the treatment, then 4 to 6 hours after the treatment, and every 12 to 24 hours. Plasminogen also before starting the treatment, then 4 to 6 hours after starting the treatment, then every 12 to 24 hours. Coming to the contraindication for anticoagulation and thrombolytic therapy, the absolute contraindications, they involve if there is central nervous system surgery or ischemia within the past 10 days, or there is any invasive procedures within the past 3 days, or if the patient neonate is having seizures within the past 48 hours, or there is any active bleeding. For related contraindications, if the neonate is having platelet count less than 50,000 per cubic millimeter or less than 1 lakh per cubic liter in critically ill neonates, or their fibrinogen level is less than 100 milligrams per deciliter, or INR is greater than 2 if the neonate is having severe coagulopathy or hypertension. If there is any bleeding due to thrombolytic therapy, it can be treated based on the severity of the bleeding. If there is a localized bleeding, we can apply pressure and administer local thrombus to provide. We also provide supportive care. And the therapy, it should not be stopped if the bleeding is controlled. If there is any severe bleeding, then we can stop the infusion and we can administer cryoprecipitate, 1 unit per kg. If there is life-threatening bleeding, then stop the infusion and give cryoprecipitate and infuse aminocaproic acid. Surgical thrombectomy, it is usually preferred when there is life-threatening organ or life-threatening failure is there. Otherwise, it is no role in neonates. Thank you.